Hi guys, welcome back. The topic we're going to study now is acute lymphoblastic leukemia, which happens to be the commonest tumor in children, much ahead of brain tumor and then neuroblastoma. This is also the commonest leukemia in children as well. And the highlight of this tumor, the two clinical features that you will hear me talking again and again during this entire course of discussion would be one, that this tumor can cross the blood-brain barrier, contributing to CNS leukemia and features of meningismus and features of raised ICP. The second would be that this could contribute to development of a testicular lump. That's really very peculiar because this cancer can cross not only the blood-brain barrier, it can even cross the blood-testis barrier. You see, normally testicular cancer disseminates to other organs, but I'm teaching you a hematological malignancy that can cross the blood-testis barrier and can contribute to a testicular lump. So let's have a look at some background pathological information for this tumor. You are very well aware that majority of this tumor would be of B cell origin, and he would love to ask you in one of the choices, because it's integrated questions nowadays, that which is the commonest subtype. Now, if he puts up a question like this, what is the most common subtype of the B type of acute lymphoblastic leukemia? Your answer would be common ALL. And what he can also incorporate in the question simultaneously would be a flow cytometric marker for this one, that would be CD10, which is also called as CALA, and this can be associated with Philadelphia chromosome. Anytime Philadelphia chromosome is associated with acute lymphoblastic leukemia, it automatically becomes a high-risk tumor, and you will have to use tyrosine kinase inhibitors for management of these patients. And even while the discussion of chronic myeloid leukemia was going on, I had highlighted the fact that T9:22 translocation is not only seen in CML but can also be encountered with acute lymphoblastic leukemia. Now let's look at what's going to happen to the remaining 24% of cases. Those are going to be anyway T cell tumor, and the highlight of this T cell tumor is one, it can contribute to a mediastinal mass. This can contribute to superior vena cava syndrome, then it can contribute to even chylous ascites. I mean, there's a mass effect in the chest. So if there's pressure on the airways, there could be description of stridor. So no big deal when you talk about especially the T cell variety of acute lymphoblastic leukemia. The examiner will have a lot of scope to incorporate clinical features, mainly because of the mass effect of mediastinal lymphadenopathy. Another feature which you can remember from the T alphabet, T cell acute lymphoblastic leukemia is associated with development of testicular involvement. I have already sensitized you to the fact that testicular lump could be described in these cases of acute lymphoblastic leukemia. And therefore the question that arises both from the I would say the parents perspective, because they're going to ask you, doctor, why my child, or from the examiner's perspective would be what is the etiology behind it. So I'll use a short mnemonic here which will help us remember the causes gradually. Alphabet A, you see, what I've done is as in contrast to a conventional textbook data, I'm just trying to organize the information from the fashion that you can remember. So the first one that I'm describing is actually a neurocutaneous disorder. The details of this neurocutaneous disorder, which involves the spinocerebellar pathways and therefore contributes to ataxia, telangiectasia, which is visible in the white of the eye, the sclera, where you will have a thick leash of blood vessels, plus lymphoreticular malignancy, acute lymphoblastic leukemia, is described even in the epilepsy lecture. Then is another disorder of defective DNA repair, that's gonna be Bloom syndrome. And the next entry again with alphabet B, I would rate that as an important one to be remembered, that is benzene exposure. Option C would be with respect to chemotherapy. Now again a very interesting thing comes up. You have given chemotherapy to a person, the anti-cancer drug has resulted in resolution of the original tumor, but has given the patient a secondary malignancy by the name of acute lymphoblastic leukemia. Look at the surprising thing that I'm teaching you, that this particular person was, let me say, treated with nitrosurias. Now this person will definitely respond. Whatever is the primary tumor, that will respond. But the bad news is that subsequently this chap, after a few years, will end up with development of acute lymphoblastic leukemia. So two classes have to be remembered: epipodophylotoxins and nitrosurias. This is akin to what I have described even in acute myeloid leukemia, where I've described a person had received topoisomerase 2 inhibitors and it developed AML subsequently, or he had received, let me say, alkylating agents and he ended up with development of acute myeloid leukemia subsequently. So the concept behind point number C here is secondary malignancy. D is relatively easier, Down syndrome. Well, children with Down syndrome, anyway, since I said children, so acute lymphoblastic leukemia will be common. And if he specifies which subtype of acute myeloid leukemia, then subtype per se would be the M7 variety, that is acute megakardioblastic leukemia. Then we'll just expand this mnemonic a little bit more so that we can remember a few additional aspects. I would stand for ionizing radiation. Already you have been sensitized to my statement. I think by this time this is imprinted in your brain that radiation causes all except chronic lymphocytic leukemia. And then alphabet I would also use this opportunity to describe alphabet I for an infection. The virus that I'm talking about here is called as HTLV1, human T cell linked virus. And the importance of this I'll mention once I'm done with the mnemonic. Otherwise, we'll tend to go into the details of HTLV1 per se. Alphabet F would stand for Fanconi's anemia. Please do not confuse Fanconi's anemia with Fanconi syndrome, because Fanconi syndrome is a defect of proximal convoluted tubule that I've described in Wilson disease. Here I'm talking about mainly congenital aplastic anemia, where there's a possibility of even a person developing ALL. Then his patients are Klinefelter syndrome. I mean, whenever they're gonna talk about a tall male, but at the same time is having gynecomastia, small testis, the phenotype that I've described is very classical, and these patients can also be having a development of ALL in their future life. Two more entries before we are done for this one. One would be neurofibromatosis 1. So traditionally, when we are reading about a neurocutaneous disorder like ataxia telangiectasia, he can talk about blood cancer. But even in neurofibromatosis 1, he can talk about what blood cancer. So you very well know neurofibromatosis can be associated with even a pheochromocytoma. So they definitely have a lot of scope of the associations which can be put up in the MCQ. And then can be chromosomal translocations, one of them being Philadelphia chromosome, though I'll mention even beyond that. But if Philadelphia chromosome positivity is given, that definitely tells you that the person would be having a high risk acute lymphoblastic leukemia, and tyrosine kinase inhibitors would be useful or will be used in these patients. Now, there are a couple of more chromosomal swaps that I would like you to remember in this discussion. That would be 814, then would be 411. I have spoken about 814 even in Burkitt's lymphoma. So today I'll be using the word Burkitt leukemia, not Burkitt's lymphoma, Burkitt's leukemia. That would be when we discuss the subtypes of acute lymphoblastic leukemia in the workup of these patients. But 8:14 is to be remembered for both ALL as well as Burkitt's lymphoma. Then the next chromosomal swap to be remembered is 1:19. So getting these numbers, I would say, right, is of paramount importance in the exam, because subsequently I'll be telling you how to remember per se low risk versus standard risk versus high risk patient. In pathology, they talk about good prognosis, bad prognosis. But for us, from treatment perspective, if a person is high risk or very high risk, we would like to go in for a stem cell transplantation right in the first remission. Whereas if a person is low risk, standard risk, I would be more comfortable giving chemotherapy for the patient. The initial anti-cancer drugs would be more than sufficient for management of this case. So from the medicine perspective, the slide that is definitely to look out for or watch out for in this discussion would be when we talk about the grading of the risk in these patients, and therefore the treatment that we give to these patients based on the risk strategy, or I would say based on the number of risk factors which are present in a particular case. We would like to be more aggressive in our approach, especially if it's like a high risk case, then TKI would also be used. Now comes the aspect of HTLV1, and for this there are two, I would say, points which are to be remembered. One, that it can contribute to development of adult T cell leukemia. And when they're going to give you a peripheral smear picture of this adult T cell leukemia, it will be very characteristic, because you would be able to definitely make up lymphocytes, because lymphocytes have a very big nucleus. But this nucleus will be having a very peculiar, I would say, nucleus, which would look something like either a flower, or I can use the word clover leaf. So you would have read this MCQ, flower cells are found in, that is acute lymphoblastic leukemia. That's a very standard question, I would say. And the representation would be a basophilic nucleus. I mean, I've drawn it red, but that does not mean that it is actually eosinophilic. It's a basophilic cell, a basophilic big nucleus. The cytoplasm will be pushed to the periphery. Do not confuse this with a situation where the nucleus is indented like this. The one that I've highlighted at the moment, though you will definitely see slides in the image-based perspective even in pathology. Here I'm trying to hand draw this to get the right perspective. Do not confuse it with Sézary cell, which definitely does not look like a, I would say, a flower, and there is a constriction bang in the, I would say, right at this area. If I just put a pointer to this, you can see a constriction present right in the middle of the nucleus. So Sézary cell is what you encounter with mycosis fungoides, which is a cutaneous T cell lymphoma and is discussed in the topic of non-Hodgkin's lymphoma. The flower cell will anyway be very, very characteristic. And the second feature of HTLV1 is a neurological one, that is tropical spastic paraparesis. So over and above the I would say the Y component here, the etiology component, it is always a good idea to remember these allied aspects, which I've also said, especially with respect to HTLV1, which is one of the risk factors due to which a person could be developing a T cell leukemia. And at this moment, you can remember T cell leukemia, alphabet T, I told you, can be presenting even as a testicular lump. Once there is development of CNS leukemia in a person, though I'll be describing the sequence of events, how the disease will evolve, I would like to handle CNS leukemia right away because this would be one of the primary aspects that they would love to ask in the exam. Now, don't be under impression that CNS leukemia cannot occur in acute myeloid leukemia. Yes, it can occur, but the prevalence is more in acute lymphoblastic leukemia. And because of this, he will either talk about meningismus, he will talk about nuchal rigidity in this patient, and he will describe features of raised ICP. And why this is important to study is because we also perform lumbar puncture during our diagnosis of acute lymphoblastic leukemia because I want to pick up CNS leukemia. But the next statement that I say has to be listened very carefully. You see, let us assume person is not having CNS leukemia at the moment, but you are doing a lumbar puncture because in the standard protocol it is mentioned that lumbar puncture should be done in all cases of ALL. When your needle is going inside, it might puncture a blood vessel. And when the needle will puncture the blood vessel will rupture and the cells might actually get disseminated into the CSF space and you would have caused CNS leukemia in the person. It was a ruptured blood vessel en route, when the needle was going inside, when you were doing lumbar puncture, that popped off in the blood vessel I'm talking about is in the epidural venous plexus. And this has resulted in this patient now developing a CNS leukemia. So while doing this procedure of lumbar puncture being as a standard part of the protocol, some experts state that you might actually cause the person to develop this manifestation, which is why you will see me talking about intrathecal methotrexate being given to the patient in the same sitting. When you're doing lumbar puncture, you don't know at the moment whether he's had CNS leukemia or not. But still, after putting in the lumbar puncture, taking out the CSF and sending it to the pathology department for centrifugation and evaluation, you have to give intrathecal methotrexate to this patient to prevent this, I would say, iatrogenic induced CNS leukemia. The manifestations are mainly raised ICP, meningismus. The cell count in these patients of the CSF will definitely be more than 5. You very well know normally 0 to 4 lymphocytes are present in the CSF per cubic millimeter. Here the count can obviously be, it could be even 50, it could be 500, no big deal. I'm saying just borderline scenario, but the number will be more than 5. And when you are gonna centrifuge it in this sediment, you will be able to see the cancer cells present in this patient. And he can also say that what test can you do imaging from the imaging perspective. Then we can definitely do a CT, especially a contrast in a CT for the METs, the leptomeningeal METs, which could be present in these patients. You see, when you read about breast cancer, even then they talk about leptomeningeal metastasis. Breast cancer is one of the important reasons for leptomeningeal metastasis in adults, but in pediatric age group, we are going to talk about leptomeningeal metastasis with respect to CNS leukemia. So the main highlight at this particular point of time would be to get the Y right. I've just tried to organize the data in a better fashion than the weight is given in a textbook. I've just tried to put up I would say a mnemonic here. Not very great, I would say, because the details are so many. But then at the same time, this would definitely help you out with these questions which have overlap from pathology. And now I'm going to describe to you the timeline of how the clinical presentation of this patient or how the disease will evolve. So now I'm describing a very chirpy, happy, brilliant kid. He's something in the range of about 2 to 8 years of age. Let me say we take an average 4 or 5 years of age. He had just started going to school, and there would be, I would say, a very fast progression of the disease. This disease either occurs in pediatric age group 2 to 8 years of age, and can occur in adults also, but if it will occur in adults, it will usually be after 50 years of age. And the mother is telling me that 3 months ago or 4 months ago, my child had won a race in the school, or maybe he had participated in some fancy dress competition and he got a first prize. So the mother was like, my child was very active, but I don't know, doctor, what's going on. Like, you can see that he has become very pale in the previous 3 months itself. In fact, for past couple of days, he has also been having bleeding from his nose. So initially, you very well know that in children, epistaxis can be due to fingernail trauma. So they had taken him to the nearby friendly ENT doctor who had done a packing. But then once the packing was removed, the bleeding had resumed, and the ENT doctor also noticed some bruises over the body of the child, maybe some petechiae. So he told the parents that I think there's some medical cause, and you please take him over to a physician or to a pediatrician. In these patients, because lymphoblasts which are immature are gonna be proliferating in the bone marrow, and these immature cells, all they do is multiply. They don't know how to fight properly, so infections can definitely be present. So this child might be admitted in your hospital. I mean, if you look at the history here, within 3 months, this child who was winning a fancy dress competition or winning a race in his kindergarten or nursery class has now been admitted in the hospital for maybe 2 episodes of pneumonia in past 2 months, along with bleeding and even a progressive pallor. Today, since the child was very unconsolable, the child was crying. You see, if you see a child crying very vigorously in your OPD, you might try to console the child by putting your hand over the chest of the child or just touching the leg of the child, telling him, see, I'm not going to hurt you, because anyway you have to physically examine him. So when I touched the leg of the child howled even louder. I first thought that, as a doctor, when you're gonna touch a child and the child is not very comfortable with you, or you are doing a first consultation, if you touch a child because you are a stranger, he will anyway withdraw his leg and he will howl. So first I thought maybe because of my touch he howled, but the mother said, I don't know, doctor, this child, he does not sleep properly at night, and when I touch his legs, he cries much louder. Even when you are going to touch the sternum of the child, you will notice a change in the facial expression and exquisite sternal tenderness. All of this is happening because there's a bone marrow expansion. You see, periosteum is the pain sensitive structure in the bone. So when there's a clonal expansion of immature cells in the bone marrow, these cells are going to take up some space. So they're gonna stretch the bone marrow, and the stretching of the periosteum contributes to pain. So every time you read about this word sternal tenderness in a child, you know the fact that the question is talking about acute lymphoblastic leukemia, considering that I've described the age and the routine manifestations. And if the diagnosis is not made at this point of time, then there would be dissemination of the disease out of the bone marrow, and even there would be organomegaly developing in these patients. So the same patient now will be having a hepatosplenomegaly. The disease can then even spread to the lymph nodes, and there would be a lymphadenopathy. And if this is hilar lymphadenopathy, like for a T cell leukemia, mediastinal mass, then he has all the luxury, the examiner has all the luxury to incorporate aspects of superior vena cava syndrome, facial congestion, collaterals developing in this child. I've already sensitized you to the fact that these patients can be having the tumor crossing the blood-brain barrier, and CNS leukemia features could be occurring. So that could be in the form of raised ICP, development of multiple episodes of vomiting, and even a 6-nerve palsy. Testicular lump or testicular mass can also be described. Feature number 7 and 8 definitely help you pick up this disease, along with the standard features which are mentioned from point number 1 onwards. And this is the usual progression. I mean, we start with pallor, and this is stormy onset. It would be, I mean, the mother herself will say, sir, my baby was like, almost pink, like in a baby's palms. If hemoglobin is good, the palms would look pink, the soles would look pink. So she will tell you very categorically, sir, look at the palms of my child, he's become totally white. I mean, in Hindi she'll say, bacha safed ho gaya hai. And along with these other manifestations would help you pick up that there's a possible malignancy present. So let us now look at the workup of these patients. And obviously the investigational choice for these patients would be to go ahead with the bone marrow aspiration. But I'll just go with the flow here, the protocol. I'll be doing a complete blood count. Because the normoblasts will not be able to proliferate properly, the hemoglobin of these patients would be lesser. The anemia would be normocytic, normochromic. TLC in these patients initially can be normal, it can be lesser, it can be gross elevations also. In the advanced phase of the disease, the TLC can be grossly elevated to the level that you could be having even leukostasis, though the incidence of leukostasis is more in acute myeloid leukemia. Remember these words. Leukostasis is more in acute myeloid leukemia as compared to acute lymphoblastic leukemia, but gross elevations of TLC up to 1 lakh per cubic millimeter, which will be written as hyperleukocytosis, would definitely be present, and more cell count can cause a sluggish circulation. Then there are two needles which are available, and the images of these have already been shown earlier. That could be Sala's needle, or we could be using a Klima's needle for performing a bone marrow aspiration. The site I will be using will be a posterior superior iliac spine. I can give local anesthesia. I can give propofol or ketamine to the patient. Propofol would be recommended. If it's not available, then obviously ketamine can be given, and I will be doing a bone marrow aspiration. The cutoff for diagnosis of leukemia would be more than 20%, and the histopathologist's job would be to then look at the morphology of cells. You see, from the morphological perspective, there are three subtypes of acute lymphoblastic leukemia. They would be classified as L1 variety, L2 and L3. So just like you will notice that in acute myeloid leukemia, I've talked about acute myeloid leukemia not otherwise specified and mentioned various subtypes. At the moment I'm mentioning L1, L2 and L3. Of this, L1 variety is the commonest one, and for the L3 variety, they would love to ask about the following aspects. L3 variety is also referred to as Burkitt's leukemia, not lymphoma, I'm talking about Burkitt's leukemia. Then this is a mature B cell acute lymphoblastic leukemia. Then he'll ask you the flow cytometric marker here, that would be CD10 positive and surface immunoglobulin. Subsequently, he will ask you regarding the chromosomal swaps associated with it. So that would be 814. I hope you recall for Burkitt's lymphoma, number 8 will come up again and again. Just like chromosome number 14 comes up again and again in multiple myeloma, you will notice that here chromosome number 8 is going to be repeated again and again. So that would be 28 translocation. Now the same bone marrow aspiration sample will also be used for immunophenotyping and cytogenetics. From the perspective of cytogenetics, they would like to ask you regarding the chromosomal swaps. So though I mentioned them already in the discussion, even on the first slide, let's just use this opportunity to practice the chromosomal swaps related to acute lymphoblastic leukemia once again. In cytogenetics, we'll be doing FISH, chromosomal translocation can be picked up, Philadelphia chromosome anyway in. Then would be 814, which I told you can be associated with Burkitt's leukemia. Then can be 411, and then would be 119. And why I have mentioned them again is because very soon I'm going to talk about determining what is the best strategy for these patients based on whether the person should be called as low risk versus standard risk versus high risk and very high risk. In pathology, they talk about good and bad. Here I'm going to talk about the risk assessment, and that is why the chromosome names have to be practiced once again. In some MCQs, he will also like to test a bit of your cytochemistry, and he can say that this person's tumor cells are TDT positive. Now, meaning of the word TDT positive basically is, I'll write the full form of TDT also, but basically the concept is that this cancer cell is having overactivity of DNA polymerase, and you very well know that if DNA polymerase is going to work much more than normal, then that means that the multiplication of the cell is definitely on the higher side. The full form of TDT positivity would be terminal deoxy nucleotide. So always a good idea to, write down the short forms whenever they are described. So it would be terminal deoxy nucleotide. And then the last T would be standing for transferase. In simple words, I will say that the meaning of this TDT positivity would be high cell turnover. So whenever you read TDT positivity, it means that things are really going bad. The cancer is multiplying very fast. And why am I worried about this? What's the impact? Why am I as a physician worried? Because higher is the cell turnover, more will be the chances of tumor lysis syndrome the moment I give chemotherapy. And if I have a tumor lysis syndrome, the kidneys will shut down, and that is where the awareness of this situation is very much I would say awareness of this fact that tumor lysis syndrome can occur with acute lymphoblastic leukemia is of paramount importance. Just to give you the seriousness of the problem, I can describe a cancer which doubles every 24 hours. A cancer that doubles every 24 hours is Burkitt's lymphoma. That's a non-Hodgkin's lymphoma and is discussed subsequently in the app. But Burkitt's lymphoma, the tumor cell turnover is very high. So when the cells will die, the DNA will break down, uric acid will be produced, and these uric acid crystals can block the tubules of the kidney, contributing to acute tubular necrosis in a patient. So tumor lysis syndrome, though it has been discussed separately also, but then this definitely has to be taken care of. So just to give importance to this, I'll say that I have talked about two investigations initially. The routine counts, a bone marrow aspiration report has come, and for point number 3, the third investigation that I'm going to do in this patient is mainly to identify whether tumor lysis syndrome can occur in this patient or has already started in this patient. You see, when I will be checking out the electrolytes in tumor lysis syndrome, because cancer cells are rich in energy. So ATP, adenosine triphosphate, the phosphate, when the cell will die, phosphate will come in the blood. This phosphate will chelate with calcium, so calcium will be less. When cell will die, potassium will be released. And uric acid is anyway a big trouble here, because uric acid can crystallize in the tubules and you could have a deranged KFT in the patient. Therefore, we need to go in for hydration of these patients. We might even have to use allopurinol in these patients so that the chances of development of tumor lysis syndrome can be mitigated. Lumbar puncture is important for diagnosis of these patients, because I would like to check the CSF of these patients for leukemia cells. Now I can centrifuge the sample, and a pathologist can definitely, even in routine microscopy, identify cancer cells. I have already explained to you that while doing this procedure, the needle might pop the epidural venous plexus and you might actually introduce the leukemia cells of the bloodstream into the CSF. So intrathecal methotrexate is usually given. I mean, most experts state that to prevent this kind of an unfortunate event from occurring, that you are causing cancer cells to spill over into the CSF, it's always a good idea to give intrathecal methotrexate for these patients. I would also go in for HLA matching, because ultimately allogenic stem cell transplantation is the best way forward for high risk acute lymphoblastic leukemia, and the investigational choice for this patient will anyway be bone marrow aspiration. So next I'll be explaining to you when, on the basis of the reports, would I be classifying a person of acute lymphoblastic leukemia as suffering from high risk ALL if the age of the patient is less than 1 year or is more than 10 years. If you're listening to me carefully, you would have noticed that the standard age that I described for these patients was 2 to 8 years. I'll just go back to that slide. 2 to 8 years is what I had mentioned. So you can just remember extremes of age. I mean, as compared to the standard presentation, would classify as a high risk patient. Then higher is the WBC count, more is the risk. So WBC count normal is going to be approximately, I would say, 4 to 11,000. But in this patient, the values are going to be more than 50K. If there is a organomegaly, it means the disease has already spread. So if you read in the clinical features, lymphadenopathy, hepatosplenomegaly, a mediastinal mass, or he describes the manifestations like stridor or superior vena cava syndrome or chylomicrosis, you have to think in terms of, this favoring high risk. The next point, however, requires a bit of effort to remember. I'll put it like this, two words: mature B cell versus immature B cell. When we were younger, we were children, right? We were immature, we were more straightforward. So I can say the word low risk. But when we become mature, when we become old, we become cunning. When I say we become cunning, we might lie deliberately, we might cheat with somebody. So mature people, I would say, are more dangerous as compared to kids who are harmless. So pre-B ALL is relatively, I would say, low risk. When I say mature, cunning people, it would mean that this is relatively more dangerous, so high risk. The next point to be remembered would be hypoploidy. Now this is definitely to be remembered. Why? Because hyper, when I'll describe it, would be for low risk. Then are some chromosomal swaps. So this is the third time in this discussion that I'm writing about these chromosomal swaps. So I think you are more comfortable with the numbers at the moment, because this is the main reason why I have written these numbers even earlier before you. That would be 814 for Burkitt's leukemia, 411 and 119. These are chromosomal swaps which increase, I would say, the need for bone marrow transplantation. Then is a finding which has been debated also, that why this cutoff, when I say blasts more than 1000. Now, obviously, there can be errors in counting. I mean, I have to rely on the experience of a pathologist in this case. And nowadays, we don't prefer to rely on somebody's experience. We like to rely on technology. So, this particular point has been debated also as whether we should consider this as one of the parameters for a high risk acute lymphoblastic leukemia. But he says that if you can demonstrate blasts more than 1000 in the peripheral smear after 14 days of chemotherapy. I will talk about the drugs which are useful for management of this patient subsequently. But my point is, when you give chemotherapy, cancer cells will die. In fact, they will die very fast to the level that you might have risk of tumor lysis syndrome and clogging up the tubules of the kidney. So you have to prevent tumor lysis syndrome. But at the same time, if you're noticing that the blasts are very much present in spite of the initial induction therapy which is given, then this would be classified as high risk. Though this value can obviously be debated, because let me say, if it's borderline values, you would definitely be in a fix whether to classify this as a low risk versus a high risk. But this is the standard data which is still mentioned in books, and I'm incorporating this data both as a combination of pathology as well as from pediatrics. Then subsequently would be absence of CD10. Remember in the starting of this discussion when I was describing the B cell variety of acute lymphoblastic leukemia, I had mentioned regarding CD10. Then is MLL positivity. Meaning of the word MLL positivity would be mixed lineage leukemias. So these are, I know these are some tongue twisting names that I mentioned before you, but it's always a good idea to remember this entire information and try to note it down by yourself. And for these patients, what would be recommended? So what is recommended here, I'll just put alphabet R means what is recommended for these patients. RE here means recommended for these patients would be to go in for a allogenic stem cell transplantation in the very first remission. So I'm gonna give chemo, knock out the bad guys, and then as early as possible try to get over the problem by giving this guy I would say bone marrow from a healthy donor. On the other hand, suppose in the question he just describes low risk acute lymphoblastic leukemia. Now there is no word in the textbook like intermediate risk. He says low risk, standard risk and high risk. I have described high risk already before you. Now on the agenda would be whenever I say person would be low risk, that would be age group between 1 to 9 years of age. That's, I would say, a little different from if you just focus on the data in the high risk, you can work out the low risk also. Just put the data opposite. Like earlier I was saying WBC more than 50,000. Now I'm saying WBC is less than 50K. Earlier I was saying mature. Now I'm saying pre-B cell acute lymphoblastic leukemia. And instead of hypoploidy, you need to watch out for the word hyperploidy. If you can remember high risk factors, in fact, I would suggest you to remember high risk acute lymphoblastic leukemia so that you can work out the low risk. Now let's look at what do you mean by the word standard risk. So standard risk would be same as high risk per se, but the difference would be standard risk would be, I'll just write it, same features as that of high risk. And you will say, sir, then what is the difference? It is just that the cytogenetics in the patient are normal, so there are no chromosomal swaps present in the person. For both low risk as well as standard risk, the main treatment for these patients would be chemotherapy. For high risk, the moment you have used chemotherapy, I mean subsequent to that, the plan is to go for an allogenic stem cell transplantation. You might notice that in some pediatric books, there is another category present. So let me just mention about this also. Features of high risk acute lymphoblastic leukemia have already been covered on the previous slide. In some pediatric books, you will read this word very high risk as well. So let's cater to that also. Very high risk basically means that you have given induction to this patient with chemotherapeutic drugs, but there is an induction failure. So especially in the setting of Philadelphia chromosome, and there is an induction failure. I said two things. I'm not saying Philadelphia alone. I'm saying Philadelphia positive and an induction failure. That is when you would classify this as very high risk patient. The learning for you guys at this junction is for low risk and standard risk, it's a routine chemo. But when it comes to high risk and a very high risk, your primary answer for treatment of choice would be allogenic stem cell transplantation. Now coming to the treatment of these patients, what I want to achieve is a complete molecular remission. And I'll be giving you two definitions with respect to complete molecular remission, and the first one that I mentioned will be answered by you primarily in the exam. See, if he says how much time, let's say the parents are saying, sir, how much time it will take, so obviously it's a long drawn battle because the maintenance phase might take or might continue for 2 to 2.5 years. But complete molecular remission can be achieved in 6 to 16 weeks of start of chemotherapy. The drugs will be talked about subsequently, but this is the time it will take to achieve a complete molecular remission. Now, the parents will ask you regarding the success rate also. I mean, how successful is your program, doctor? So, for a high risk patient with the abnormal cytogenetics that I had described, the success rate is to the tune of 80%. But if it's gonna be a low risk patient, like a child between 1 to 9 years of age, the success rate of achieving complete molecular remission is to the tune of 90%, obviously, because he's a low risk patient. Better chances. Now, I said two definitions I'll tell you for complete molecular remission. The first one is that 99.99% of cancer cells are destroyed, that is less than 0.01% of leukemia cells or blasts are surviving, or we can physically count and say less than one leukemia blast. Remember the number and the denominator here carefully. If the pathologist is able to demonstrate less than one leukemia blast for every 10,000 normal cells, we will say this is a complete molecular remission. The technique that will tell us here would be a real-time PCR. There's a second definition also. He says if you are able to demonstrate less than 5% blasts in the bone marrow, and when I'm saying the counting of the blasts here, this would be done under light microscopy only. So there are two definitions for complete molecular remission, with the first one being more credible, I would say, and real-time PCR will be used for it. Now, to achieve it, obviously we need to talk about a couple of drugs also. So on the next slide, I'll tell you what are the drugs to be used. There's a possibility that he might describe a patient of acute lymphoblastic leukemia in whom Philadelphia chromosome is positive. Then for management of these patients, I will be using tyrosine kinase inhibitors. Do not answer imatinib in this case, but answer it from the second generation. The second generation molecule which will be effective in this case would be dasatinib. Another one is ponatinib. So, do not casually answer imatinib, as a couple of people have a habit of answering, and both of these are recommended. Why? Because they can cross the blood-brain barrier also, because I want to highlight that I need to treat the CNS leukemia component also. Another approach which we can be using for these patients is very selective and targeted approach, which would be like a laser guided missile locking onto a target. Like, let us say there's a convoy going, and in that convoy the first vehicle is carrying the terrorist and the rest of the vehicles are normal, I would say, normal people. So you want to destroy only the first vehicle. So the drone can fire a laser guided missile which will only take out that vehicle that is carrying the terrorists per se. So similarly here, our objective is not to destroy the normal cells in the bone marrow. I want to destroy only the abnormal ones. So this is a brand new approach, and we call it a chimeric antigen receptor target. It's not a combination antiretroviral therapy that I'm talking about, like we read with AIDS, and obviously you can pick that up. It would be chimeric antigen receptor target approach, and it's a brand new one, so that's why I'm spending some time on this. And the drug which is present here is to be remembered as blinatumomab. Now, once you remember these two, I would say, brand new approaches for a person who's having Philadelphia chromosome positive, let's also talk about chemotherapy for a low risk patient. This is a standard protocol which is given in pediatric books also. So we'll talk about induction, then consolidation, and then maintenance. And induction would be two phases, induction 1 and induction 2. In induction 1, we'll be using the following drugs, that is vincristine, which they will ask you causes a side effect of peripheral neuropathy. Then would be daunorubicin, which has a side effect of cardiac issues. It can contribute to cardiomyopathy. Then is L-asparaginase, and the last molecule that would be answered here is prednisolone. So most of the time they will ask you regarding the side effects of these drugs also. And along with this, because I run the risk of actually contributing to what I said was a iatrogenic introduction of cancer cells into the CSF, so intrathecal methotrexate will anyway be used when you're using lumbar puncture or performing lumbar puncture initially. but it has to be given subsequently in these patients also to handle the CNS leukemia component, because it will develop in the long run. In induction 2, the drugs which are used are 6-mercaptopurine, methotrexate, and cyclophosphamide. This cyclophosphamide is the one which is a alkylating agent and contributes to side effect of hemorrhagic cystitis. Along with this, cranial irradiation will also be used. So in your pediatric wards, you would have seen a lot of bald children. And because these bald children might be made fun of by other children, maybe at school or maybe their own brothers and sisters, so you would be encouraging either the mother or the father to shave off their head also. So lots of time in your pediatric wards, you would have seen these kids separately kept in the leukemia ward, and they are the ones whose parents would also be bald. This cranial irradiation will anyway contribute to hair loss in these patients. It's usually about 18 to 24 GY which is required, and we will deliver this in 12 fractions. So it's fractionated cranial irradiation. A side effect of this cranial irradiation has also been asked. Like, this child was having ALL, he was having CNS leukemia, so cranial irradiation was given in childhood, and this patient in later age group can end up with development of which brain tumor? The answer is what I've written already before you, meningioma. In spite of giving a fractionated cranial irradiation, risk of meningioma is very much present in these patients. Now we will talk about the next phase, that is consolidation phase. This consolidation phase would be something in the range of about 14 to 28 weeks. So it's a long fight at the moment. Let's look at the drugs. I'm going to carry over some of them which are already given on the slide superiorly. Cyclophosphamide, then is vincristine and daunorubicin. I could have also written doxorubicin, but considering the toxicity profile versus the safety profile, I mean, it's daunorubicin that would be recommended. So 3 are carryovers from the superior information that I've mentioned before you. The add-on information here is an additional drug, that is cytosine arabinoside. So if you can remember this algorithm, great. If not, then let it go. And just remember the main issues, like specifically for high-risk patients, we are preferring the treatment choices: allogenic stem cell transplantation, usage of TKIs, the second generation ones which cross the blood-brain barrier are the ones which are recommended. Targeted approach can be remembered, and then initially on this slide, it is mainly this part of the slide which will be asked to you from the pharmacological domain, though my job is to obviously tell you the entirety of the data. So next I'm going to talk about what drugs are going to be useful in the maintenance phase. You can remember ICM, induction, then consolidation, then maintenance. And in maintenance, the total duration of treatment might go to approximately 2 to 2.5 years. The drugs which are used are initially the same: vincristine, daunorubicin, L-asparaginase, and prednisolone. And along with this, 6-MP, 6-mercaptopurine will be given. And if the person is not responding to this, if I say what is definition of relapse, a relapse would be defined as more than 5% of leukemia cells in the bone marrow on a light microscopy. Why that is important for you, that cutoff of 5 to be remembered, is because of the fact that I just told you complete molecular remission. One of the definitions I told you was less than 5 blasts in the bone marrow. If it is more than 5, then you would call it a relapse. So these are the technical aspects that I would like you to remember for this particular topic. Especially towards the end, it becomes a little overbearing when you have to remember multiple anti-cancer drugs. So I would suggest you to rather focus on the side effects of these drugs from pharmacology as compared to the, remembering the treatment algorithm per se. It's very unlikely in all these years I've never seen questions on ALL talking about the treatment algorithm. They're mainly focusing on the side effect of the drugs. They definitely love to ask regarding the pathological aspects that I've highlighted. They would love to talk about high risk versus standard risk patient, and then subsequently the first slide which I highlighted, the why of this, the etiopathogenesis of the disease, the associations, is the primary aspects which should be focused on this particular topic. And yes, lots of information here, but at the same time, the more data you crunch, the more information you remember, the more you push yourself, you will be able to enhance your mental capacities and would be able to secure good ranks in the exam. And I have seen everybody who's put his heart and soul into it. If you put your hand on your heart and say, I'm gonna do it, right, and nothing is gonna stop me, and every day I'm gonna keep on repeating the same thing again and again and again till the wall breaks, right? When I say wall breaks, it means finally the view for you is gonna be that of a successful career. So keep the focus on, guys. That's what I always say, keep hammering. till you are able to get to your target. Thank you so much for your patience and hearing me out.